So I will start with a question which is coming from Russia, I suppose. And the question is, if this hypercoagulable state, I imagine is for Professor Levy, is the hypercoagulable state is provoked by the virus, or is the second inflammation wave that activates the coagulation system? Meaning that if we eliminate the virus, the hypercoagulability will persist.
So any acute infection causes this hypercoagulability state. Part of the problem with this particular virus is its cytotropic nature, where it then not only affects probably multiple cellular issues, but it clearly causes an endothelialopathy, what's now called endothelialitis. This has been long been described with traumatic injury. And what happens is, and from some of the post-mortem, you see capsase staining, which means that it's lymphocyte, it's cellular apoptosis or cell death. So now you've got a hypercoagulable state induced by acute infectious process, which then now you're rolling over a surface that's totally de-endothelialized. You've lost the glycocalyx. So you have a hypercoagulable systemic state, a local vascular endothelial dysfunction, and guess what? The microthrombotic issues. But what's interesting is the hypercoagulable state also produces a potential for macrothrombosis, i.e. pulmonary emboli. So it's one of those sort of bad scenarios where you got micro, macro, and you got all the other issues. But the unique endothelialopathy that occurs, in my view, with the virus really contributes. Now, gram-negative and other organisms cause endothelial injury as well, loss of glycocalyx, but they don't seem to produce the apoptotic cell death, i.e. the shown by capsase staining. So that is really, I think, and it's consistent with any infectious state. For instance, in that patient I first presented, patient ended up having mycoplasma. But Professor Elami, he is also an expert in vascular states, and we have other individuals, and Professor Rodriguez. It would be great for them to weigh in too, because this is an international perspective, and ça vaut mieux peut-être en France ou possiblemente en España es bastante mejor. So if you can, can we let those guys weigh in as well? Is that okay?
Okay, thank you. So I will pass the pass to Elalami.
Okay, I'm sorry, you're running the show. Apologies.
I will. So the question for Elalami is, if do you think that if we manage to eliminate the virus, can we stop the process of hypercoagulability and to change the degradation, the degradation process and the disease process?
No, you're right. You're right. As Gerald said, the storm has many consequences in the vascular compartment, and we must pay attention to that. Let's say oxidative stress, and the stress is a small word with big consequences, and the stress is still there for a long period of time. And just as analogy, you have to pay attention, for example, in pregnancy, with the postpartum period, well known as a high-risk period, and in some, let's say, pregnant women, which is not a pathologic situation, the pregnancy, but we know that in the postpartum period, with that, let's say, the conflict between the content and the contents. So the hypercoagulable states, it's there for a long period of time, at least 6 weeks and sometimes 12 weeks in some particular, let's say, profile of pregnant women. So we must pay attention to the risk factors in each COVID-19 patients. And in case of severe disease, for sure, the enemy, the prothrombotic, let's say, enemy is still there for a long period of time. And as you mentioned, all of you, so maybe we need to prolong that prophylaxis and that protection to cover and to, let's say, control this hypercoagulability in this patient for a long period of time.
So another question, which is quite relevant from the discussion we have, is coming from Corfu, Greece, and from a colleague who is a legal medicine there. is one of the first who reported in Greece, and he sent us a nice video with the clot from a body. And he says that he's asking if we should change the name of the coronavirus SARS-CoV to a to another name that contains thrombosis. Meaning that the problem is thrombosis and not just SRS.
But again, inflammation, coagulation are a synonym. So I think it's the both, let's say, the two faces of the same, let's say, pathology. And we have seen that there are many, let's say, actors leading to this dramatic situation. And the thrombosis, it's not the sole cause for death in this case. So, in my opinion, the organ failure, the cytokine storm, the balance between, let's say, the capacity of this vascular compartment to, let's say, control this hypercoagulability, etc., all these are contributing to the clinical consequences. So, in my opinion, it's a for sure, it's like a Swiss knife model virus with many consequences. But anyway, thrombosis is only one phase of this not such diamond virus.
The question for Professor Rodriguez, Damelo Rodriguez, sorry, is that the presence of the mutation, factor V Leiden mutation in the population, which is quite high, the question says, in Spain. Do you think that it contributed to the high rate of thrombosis and mortality in Spain?
We don't know so far. I mean, we commonly we don't test for thrombophilia in the acute setting of thrombosis. We wait for three months to test patients, so we have no information about that. We will have it because we have many young patients. In my hospital, we have more than 100 patients with VTE that we are following in the VTE clinic, and many of them, especially those who are young, we will be tested for thrombophilia. If I have to guess, I would say that no. The prevalence of factor V Leiden mutation in Spain is around 3 to 5% of the population, and we know we have many studies demonstrating that the weight of factor V Leiden in the pathogenesis of thrombosis is actually low. We don't use factor V Leiden to take decisions regarding anticoagulation in these patients. So I don't think, I mean, it will play a role, but I think it's small probably in these patients.
It's a question to Marc Garnier. It is impressive that you propose that the organization of the intra-hospital committee for the management of surgery, program surgery in COVID patients has to take into consideration the stock for the plasma, for the transfusion, and also for the drugs. Do you think that this strategy should be applied only during the crisis of the COVID, or it should be established in the institutions even during the calm period like now and later on, waiting the second wave?
Well, I believe it's of great interest during the crisis, but I guess it's one of the features that we adopted for the COVID-19 crisis that may last after the crisis. For instance, in my hospital in Paris, last week we have an alert from our blood delivery agency, and the stocks of there is no stock for blood product with negative rhesus group, no stock at all. So all the surgery with planned intraoperative transfusion has been delayed and postponed for at least 1 week. And it's very difficult to make campaigns for blood donor, as the usual local and the usual place to collect the blood are now closed until the end of June in Paris, and donors have not come back to the collect places. So the states of blood products and even with the pharmacy for anesthetic drug shortages have been taken into account. Yes.
Thank you. Another question is from Serbia, and I suppose it's for Professor Levy. Is that if you think that thromboelastometry or thromboelastography could be used for the monitoring of coagulopathy in ICU patients and optimization of the antithrombotic treatment?
My lab did the work at Emory when I was at Emory on the work I got thromboelastometry, the ROTEM approved in the United States. I think if you can't get a fibrinogen level, it makes sense to do a TEG or ROTEM from a viscoelastic test but to me, all it shows you is that the maximal clot firmness or maximal amplitude is elevated and you're hypercoagulable. But I mean, to me, anybody who's hyperfibrinogenemic is already hypercoagulable. Look at pregnancy. We talked about that. It goes to 600, 500, 600, milligram per deciliter or 5 to 6 grams per liter. We've been studying fibrinogen, not only repletion, but also hypercoagulability for years. Too much is not good and not enough is not good. I think it's great if you can't get a reasonably timely fibrinogen level. Other than that, to me, what you really see is maximal clot firmness, maximal amplitude on either test, and you use that as a hypercoagulable scenario. Yes, indeed, it looks at some effect of platelet function, but it's highly driven by fibrinogen levels. And we used that years ago in our early work on fibrinogen repletion. So bottom line, yeah, it's a great test, but remember, we got to do other tests as well. And D-dimer is an acute inflammatory marker as well. So I just think that, in quick comment, the lysis that you see on TEG and ROTEM is exquisitely insensitive to D-dimers. And I had a patient who ruptured his aorta, profound DIC, and we said ROTEM, his D-dimers were greater than 100,000 nanograms or 100 mics per mil, but he had a total normal lysis on ROTEM. So bottom line, helpful but limited, my opinion.
Yeah, we have the same experience with ROTEM. It's a good tool, intellectually interesting tool, but with a limited useless, or not useless, but it's not very useful in this context. Now, I have a question for Dr. Economakis. It comes from Middle East. Apparently, it was not clear, the algorithm that you presented. So could you specify how is this platform for the COVID Compass?
Sure. What we are doing is getting all the risk assessment models that you are creating, and with our tool we are putting there all these risk assessment models in order to give the healthcare professionals a very user-friendly tool in order to provide the data for the algorithms, and then have a very humanized result for the healthcare professionals in order to support them in their decision making. So all the model is based on how we can put all the new risk assessment models that your industry creates. And as for COVID-19, it was something very new, and a lot of models it had to be created based in a few days or in a few months. So we have to give back to healthcare professionals a tool in order to monitor data through your algorithm. So they are very good quality data, since they are based on your algorithms, and then we give back to the healthcare professionals recommendations and supportive tools in order to make more accurate decisions. And then again, we use for analytics all the data.
Thank you very much. And the last question, I think it's for all the panel, is that if the development of the plasma tissue kallikrein inhibitors could be a good target for the treatment in COVID patients. I suppose that the underlying idea is that all the story starts from the intrinsic and the contact system activation.
So can I make a comment, since I've worked a lot with contact activation inhibitors, kallikrein. First thing, a protein is available, it's a reasonably potent kallikrein inhibitor, and it's actually available now in France. There is a drug that I worked extensively for angioedema called ecallantide. Originally was DX88, and it's approved. It's a kallikrein inhibitor. The problem with inflammation is all of the amplification that occurs. Block one pathway and everything else gets activated. Thrombin tends to override it. The bottom line is it's an interesting concept, but therapy has to be multimodal. And, we can inhibit some of the serine proteases, but you still have the virus that rages on for days and creates the ongoing thromboinflammatory stimuli. Bottom line, interesting concept. And the contact activation pathway probably is critical for some of these inflammatory, but the problem is that, you need when you shoot skeet, you don't use a 308 30-06, you use a blast of a shotgun, 12 gauge. Sorry to do this US style, but anyhow, you need a multimodal therapy, my opinion. What does everybody else think? Professor Alami, thumbs up.
I totally agree with you, Gerald, as usual, but I totally agree, because in fact, facing such, again, multi-dimensional enemy, we need to, let's say, faces all these, let's say, consequences. Anti-inflammatory drug, potent anti-inflammatory drug, antiviral drug, and anticoagulant, and other, let's say, resuscitation methods, etc., etc. So I think, in my opinion, is that, let's say, we need a multidisciplinary, let's say, faculty to understand. So we need to, again, build a let's say, potential approach to control all these issues in these complex patients. So I totally agree with you. It's one proposal, it's one finger, and we need, as Shiva, many hands to control that in COVID-19 patients.
This is a good idea. Now, it's because of the issue on heparin and the monitoring of heparin using the anti-10A activity and not the APTT. This is something that we have to underline. There is a question regarding the heparin resistance in COVID patients and the potential role of heparinase in patients with resistance to COVID. Any comments about that? Have you faced in Spain first the resistance to heparin?
I've done a lot of work with heparin resistance and cardiopulmonary extracorporeal circulation. Remember that your assay of partial thromboplastin time is a clot-based assay. So hyperfibrinogenemia really makes it difficult. Thrombocytosis also, we release PF4 and neutralize the heparin. The problem is it's hyperfibrinogenemia. That's where the 10A assay is probably very helpful. But remember, hypercoagulability is also a multiplicity of issues, from microparticularization and all the things that happen. But heparin resistance with COVID-19 especially depends upon the assay that you use. The reality, and the antithrombin is relatively normal. It's the hyperfibrinogenemia that I think really significantly contributes. That's my thought. And that's basically on some of the other heparin resistance scenarios that we have, have looked at through the years.
Thank you very much. So I have one last question, is my question, is that in the paper that we are going to publish soon, that Ismail developed, we had the observation that patients with COVID, practically they have compensated DIC, not the over DIC. And there were about 10% or 8% of patients who appear with a compensated DIC score higher than 5 at the first day of admission to the emergency and then to the conventional ward, meaning that probably there are some patients at home who have this type of DIC. And we were wondering with Ismaila if if the score of the ISTH score that we have has been developed for sepsis, and we should reconsider the score for DIC related to COVID. Do you think that it makes sense, this approach?
That's a really great question. There's different scoring systems. I know I work closely with the ISTH, but the reality is I prefer the Japanese acute care medicine scoring, the JAM score, because it doesn't even look at fibrinogen.
Yeah.
The problem is that you can have profound DIC with a normal fibrinogen. Look at eclampsia. I mean, your fibrinogen is maybe 250, 300, and that's normal, but you have other issues. I think the problem is the scoring is all kind of complicated. The reality is that there's a sepsis-induced coagulopathy score that Toshiaki Iba, head of the DIC committee, has worked on. I think we need to do a better job. I think your point's extremely important. And even a funnier story, a couple of years ago, I sent emails to some well-known hematologists in the United States, and do you calculate DIC score in critically ill patients or in sick patients? And none of them said yes. But I mean, it's done a lot in Japan because they have antithrombin and recombinant thrombomodulin used extensively for bacterial infections. And it's part of the Japanese algorithm, not in the sepsis 3 algorithms. Bottom line, great question, important perspective, and we need better scoring systems. And I think that was neat, some of the data that we saw earlier about some of the scoring. I apologize who presented that, but great question, important. And again, it shows the inadequacy of that. The fibrinogen probably shouldn't be included. The sepsis score is probably better because it uses some of the sepsis data and looks primarily at prothrombin time and platelet count. To me, that's critical because if you lose your endothelium, you sequester, and white cells too.
Thank you very much. I think that we have to close now. I profoundly thank you for the participation to this meeting. It's a real innovative, and people who is attending is very happy. And we have reached high levels of attendees. Thank you very much for participating. Soon we will create the database, and in addition, and I am sure that we will help the countries who do not have the experience to COVID to improve the infrastructure and the networking, and so we can save lives there. Thank you very much. Good night. Bye.
Right.